I'm Richard Edmondson. I'm the Professor of Gynae-Oncology at Manchester University, and our project was looking at trying to start to eradicate some of the geographical variations we see in how patients with ovarian cancer are treated around the UK. There was a national audit that looked at how patients are treated in England, and what it showed that depending on where you live in England, you will receive different treatment patterns. So the proportion of patients, for instance, who have an operation as part of their treatment varies enormously between different geographical areas. And that does seem to matter because survival is influenced by the proportion of patients that are having surgery. So in general, centres that have high rates of surgery seem to have higher survival rates for their patients than centres where there are low rates of surgery. And we wanted to try and investigate why that was the case and then start to develop strategies that would reduce that geographical variation and improve the quality of care for all patients. What we did was we formed a consortium of 7 centres around the UK, and we used those centres to start to collaborate together, to exchange ideas, critically to start to exchange data so that we can share data between the centres and see how ovarian cancer is treated in the different centres, and then use that to formulate tools that we can develop individual predictive models for patients. The first thing we did was we studied how we make decisions at the moment, and we make decisions at the moment through multidisciplinary team meetings where we sit in an environment away from the patient and we discuss their case, we discuss any imaging that's going with that, we discuss any pathology that's available, and we usually make decisions about what's the best treatment for the patient in that meeting and then inform the patient of that. And what we studied was how these different MDTs are working across our consortium. We found that they work in very different ways and they make very different decisions depending on who's in each meeting. That showed us that at the moment that current decision-making strategy is not really fit for purpose. And what we need to do is to move the decision away from that MDT meeting and actually put it in front of the patient and help them make the right decision for them with a clinician. So the next thing we did was then studied what patients actually want to know about the decision to help them make the decision properly. And then finally, we used the data that came from that consortium of 7 centres to start to develop the predictive models that we need to help patients make their best decision. The next step we would like to take this on is to now develop this into a clinical trial where we can evaluate whether moving that decision making into a shared decision-making environment with the clinician and adding in these personalised decision support tools actually makes a difference to UK practice.